First and foremost, I will try to keep this concise because I think I'm keeping all of us from a coffee afternoon break, so I will keep this short and sweet. But thank you again to the conference organizers, and on behalf of my research team, really excited to be able to share the DDI study results from our Bictegravir, Emtricitabine, Tenofovir, Alafenamide, and oral estradiol gender-affirming hormone therapy in people living with HIV and transgender versus cisgender women. I have nothing to disclose. I don't think I need to spend too much time on this and convincing the group of this, but transgender women are found to be at higher risk and unfortunately disproportionately affected by HIV in comparison to their cisgender adult counterparts, and this can be due to a multifactorial number of reasons. Data has also demonstrated that in transgender people or transgender women, there's unfortunately lower antiretroviral therapy or ART utilization and adherence among these patient populations. Part of it due to the fact that there's potential for gender stigma and all of those things associated with it. Additionally, there's a big concern amongst this patient population because of the paucity of data in this space, both on the patient side, but also on the clinician provider side, that potentially there's the fear of drug-drug interactions or DDIs between their antiretroviral therapy and those feminizing hormones. And so with that paucity of data and with what we know in this patient population, what we sought to study with this specific aim in our project was looking at if there are clinically significant drug-drug interactions between the most commonly prescribed feminizing hormone regimens, so in this case, oral estradiol and an antiandrogen, with the ART combination of BIC, FTC, and TAF, which is one of the most commonly prescribed ART regimens. And so for this study, we had a 3-armed parallel group longitudinal DDI study that was recruited out of affiliated clinics within the Maple Toronto Leaf Research Network. Our objective was to compare the month 2 pharmacokinetic parameters of BIC, FTC, and TAF among trans women with HIV who were taking feminizing hormone compared to their cisgender counterparts with HIV. And our hypothesis was that there would be no difference in those month 2 pharmacokinetic parameters between the groups. So looking at our study design, I did mention that three-group design. For this particular portion of the work, we're going to be focusing on the 2-group comparison that are highlighted in the blue box for you. So looking at our trans women with HIV and our cis women with HIV in the month 2 pharmacokinetics. Month 2 comparison of pharmacokinetic parameters, so Cmax, Semen, AUC of plasma, BIC, FTC, and TAF were compared. Secondary outcomes, there were a ton, but one I want to highlight for you here is from an efficacy standpoint, the proportion of participants with undetectable HIV RNA at all follow-up visits, so through that 6-month time period. There were other patient-reported outcome data that I won't be presenting in this talk that were collected at those baseline and month 6 visits as well. So for our methods, for our inclusion criteria, all participants needed to be on suppressive ART for at least 6 months prior to enrollment, and they needed to either be switched to or taking BIC, FTC, TAF at the start of the study period. In addition to that, in our trans patient population, they needed to be taking at least 2 milligrams per day of oral estradiol and an antiandrogen therapy, and no estrogen-based gender-affirming hormone therapy medication changes could be made in the 3 months leading up to their study entry. For our sample preparation, we obtained a plasma sample prior to ART and gender-affirming hormone therapy dosing, if applicable, and then at the timeframes listed for you there, a pretty intensive or standard PK time point study there. We measured all of our drug concentrations in validated LC-MS methods with the assay lower limit of quantifications listed for you on the slide there. Statistical analysis-wise, Semen, Cmax, AUC over 24 hours was calculated by non-compartmental methods, and then a comparison between groups by geometric mean ratio with 90% confidence intervals was done per FDA guidance. We defined a difference of 0.7 with our GMR as being non-significant or not clinically significant as per guidance as well. So I do want to take a step back, and I'm sure you're all curious because you're like, there's a bidirectional relationship that we'd want to look at. We did also look at the impact of Bic/FTC TAF on the estradiol concentrations as well. The highlight short summary from this with the comparison of the two groups listed for you in blue there from data presented at CROI 2025 is that estradiol concentrations were similar between trans women on Bic/FTC TAF and trans women without HIV, which that component suggested a low probability of clinically significant DDI between those estrogen-based therapies and Bic/FTC TAF. Okay, back to this study where we're looking at specifically transgender women with HIV on feminizing hormone therapy versus cisgender women with HIV on ART as well. So our demographics are listed for you on the slide, as well as the median estradiol dose in our transgender group was 4 milligrams, along with the anti-androgen therapy. Most commonly, majority were on spironolactone. I do want to note that in both groups at the 6 months of follow-up, all participants in both arms did remain virologically suppressed throughout the entire study period. Okay, getting into the plasma pharmacokinetic data. So for Bictegravir, on the screen for you is your concentration time curve with sample time on the x-axis and the plasma concentrations on the y-axis. What I want to highlight from you here, as you can see between the Cmax, Cmin, and AUC, is that all of the geometric mean ratios maintained above that 0.7 threshold that we pre-specified, meaning, again, no significant difference in Bictegravir concentrations when compared between the two groups. Tmax's, or time to max concentration, was similar between groups as well. Looking at the same schematic for FTC, again, we see similar data here with Cmax, Cmin, AUC, GMRs ranging between 0.9 and 1, essentially indicating no difference between the two groups in terms of the pharmacokinetic parameters in comparison between the two groups. Tmax's as well, again, were similar between the groups here as well. And then finally, here's our TAF concentration data. Again, you can see between the two groups, our Cmin, Cmax, and AUC still maintained above that 0.7 GMR threshold that was pre-specified, again, indicating that there was no clinically significant difference between the two groups in terms of the concentrations and pharmacokinetic parameters. Tmax's, again, were similar between the groups as well. So in conclusion, from this component of our work, we found that Bic/FTC TAF pharmacokinetics were similar between trans women with HIV on estrogen-based gender-affirming hormone therapy and cisgender women with HIV. This indicates that there's a low probability of clinically significant drug-drug interactions of oral estradiol gender-affirming hormone therapy on Bic/FTC and TAF concentrations. And together with the previously reported work from our data at CROI 2025, I think we can say that estrogen-based gender-affirming hormone therapy and Bic/FTC TAF can be safely co-administered with a low risk of clinically significant DDIs in this patient population. So with that, I'd like to thank the massive team of researchers, co-investigators, and most importantly, the participants for volunteering their time and effort to the study, as well as our funders. Thank you.